Good morning. So as Tasha said, my name is Eric Bortnick. I'm one of the new faculty members here. And I'm going to give a talk today about my interests in education research called Curriculum Development and Education Research, a six-step standardized approach. I don't have any real disclosures for this, only that the mannequin that I'm going to talk about today has been submitted as a provisional patent to the United States. I can go into that a little more. So given my interest in medical education and education research, I was asked to talk about curriculum development and the work that I did in fellowship in establishing an education curriculum for pediatricians and how I'm planning to continue to expand that work while I'm here, and also my plans for other educational scholarship and curriculum development endeavors here. So for today, the objectives for the talk are to describe the six-step approach to curriculum development, show an example of a novel simulation curriculum for primary care pediatricians in the context of the standardized approach, and describe future directions for a simulation-based surgical education curriculum for medical students. So instead of just describing my research and the project that I did previously, I thought it might be more valuable to discuss it under the context of how to create a new educational curriculum based on the standardized approach that medical educators have been using for decades. So I'm going to talk about the 6 key steps of curriculum development and use my project as an example for each step. So this on the left is the mainstay textbook for curriculum development in medical education by Drs. Thomas, Kern, Hughes, and Chen. Been around for a couple of decades and is used by medical educators around the world when thinking about designing and creating a new curriculum. It's on its 3rd edition, and the 6 steps outlined in this book are the 6 steps that I'm going to discuss today and use as a backbone for the example of my project and its development. But first, why do we care? Why is it necessary to do the 6 steps when thinking about establishing a new curriculum for your learners? For one, it ensures that you're not putting the cart before the horse. The biggest mistake that most educators or developers of a new curriculum make is to jump ahead into creating that new education the way they want to perform it without considering the needs of the learners, the needs or availability that the institution allows, or even the needs of the instructor or the creators of the other educators. So this can lead to curriculum that are not necessarily as successful as they could be. In addition, this 6-step approach allows for an objective assessment of learners and the curriculum itself, leading to improvements in subsequent iterations, which is not unlike the PDSA cycle used in QI work, which I'll talk about a little later. And finally, using this approach displays a much more rigorous methodology to your curriculum development, similar to basic science or clinical research. That makes your curriculum more attractive for publication. In fact, there's opportunities for publication at multiple different time points in the steps of curriculum development, and these are not usually leveraged well by educators when thinking about publication and talking about their work. So seeing here are the 6 steps. I'm going to go into much more detail about each one in the context of my work. I do want to point out a little caveat here is that while I'm going to discuss the 6 steps in order here from 1 to 6, it's worth noting these arrows that go from each step to each step, and that these steps are usually happening simultaneously. So as an example, part of step 5 in implementation is getting institutional buy-in and financial support, which, as you can imagine, happens early on in the process while you're performing your needs assessment and thinking about creating goals and developing your educational strategy. So in no way is this a linear or circular approach, but instead it takes time and lots of iterations to get you to your final destination, creating a good educational curriculum. So this is the example I'm going to use today. It's about creating a curriculum aimed at improving education on the diagnosis and management of undescended testicles for the primary care pediatrician. And so this is kind of the progression over time of how this started, how it looked in the middle, and where it is now. And I'll kind of go into much more detail about all these different pictures and along the way. So step 1 in curriculum development is problem identification and the general needs assessment. So this step is really figuring out what the problem is and where it is both nationally and locally, and how you think you want to do an improvement to improve the education on your problem. So you want to identify and critically analyze the healthcare need or the problem that you want to help. And you want to look at what the current approaches are for teaching this, whether the current approaches to how we treat the patients, the current approaches to how we teach the educators, the practitioners, and also society in general. And you also want to start thinking about an ideal approach on how this might need to be addressed. So in the context of my project, again, about undescended testicles, general needs assessment, undescended testicles are the most common congenital anomaly of the DU system, anywhere from 1 to 3% at birth, persisting at around 1% or so at 6 months. Undescended testicles are a risk factor for testicular cancer and future fertility problems. And according to the AUA guidelines, surgical intervention should be between 6 to 18 months old to help mitigate both fertility issues and the low risk of testicular cancer progression in the future. And as pediatric urologists, we rely on the timely diagnosis and referral from our primary care colleagues to treat undescended testicles and optimize their outcomes. And the interesting thing about undescended testicles is that this is purely a physical exam diagnosis, right? There's no lab tests, there's no imaging that really helps us. It's really based solely on the physical exam. And previous studies over the past couple decades have shown that primary caretakers and primary care pediatricians may not be very comfortable or confident in their physical exam skills or the diagnosis and management guidelines in the care of these patients. So as an example, 30 to 60% of patients that are referred to pediatric urologists for undescended testicles are seen and operated on after that 18-month window that we try to give. 25 to 50% of patients that are referred to us for undescended testicles have undergone unnecessary ultrasound imaging prior to their referral to us, which, as you can imagine, puts increased stress and anxiety on parents, increased hospital costs, and delays the time to referral to us. And additionally, some studies have shown that anywhere from 40 to 60% of patients that are referred to a pediatric urologist for undescended testicles have totally normal physical exams when examined by the pediatric urologist. As another example, this was a survey done in the UK in 2016 of general practitioners. They were asked to talk about how happy they felt when assessing patients with undescended testicles. As you can see here on the left in red, just about over a quarter felt very happy with assessing undescended testicles in an infant boy. And even fewer felt very happy with knowing what terminology to use when taking care of these patients, discussing diagnosis strategies and management decisions, both with colleagues, with the patients, and with the pediatric urologist. This could come as a surprise to us because in our specialty, as we discussed, undescended testicle is such a common condition that we see on a daily basis. However, it's possible that on more of a per provider basis or a per pediatrician basis, it's not as common as we think, which I'll show a little later, which could lead to the decreased comfort in its management. So aside from the needs of the patients, you want to think about the general needs assessment in terms of what have we tried previously to help teach the pediatricians on how to take care of these patients. And a lot of the literature talking about what has been used previously has been a lot of lectures similar to this. You go and talk to pediatricians, you give a lecture on the diagnosis and management guidelines, you ask how they feel afterwards, and they go on their way. And it turns out that doesn't really help them too much. Sometimes the lecture will be accompanied with a knowledge quiz at the end, just to give some feedback and education on the correct response. However, again, it's a one-time thing. You don't really follow up after, and it doesn't really quite seem to stick. And even on a more national level, at a QI level, the AUA tried to work with the American Board of Internal Medicine on a Choosing Wisely campaign, which is a campaign about the 5 things that physicians and patients should question and let pediatricians or adult primary care providers know. And one of the first things on the AUA about this was do not routinely perform ultrasounds on boys with orchidism. Unfortunately, many of these studies have reported variable results on improvements in measures like physician comfort, time to referral, time to surgery, or use of ultrasound. And it's possible that one of the reasons why these strategies haven't worked so well in the past is because they're really only focused solely on the guidelines of understanding the diagnosis and management, but haven't necessarily focused on the physical exam skill or how to teach how to do that skill appropriately. And as we talked about, the diagnosis of undescended testicles is purely a physical exam diagnosis. So then step 2 brings you to the targeted needs assessment. And this is where you go sort of from the more global or national approach to looking more at what's going on at your institution and at your local level. So what you want to do when thinking about your curriculum is you want to assess the needs of your specific groups of learners and understand what their learning environment is and what's available at your institution in order to create your curriculum that will be successful. It helps integrate what your desired curriculum would be into the overall curriculum that's already established at your institution at the local level. It also helps to develop communication with and support with key stakeholders throughout the institution, throughout the different departments, throughout your department and your learners in order to get a better understanding of what will work best for them in that environment. And some examples of how to perform a targeted needs assessment are listed here. You can just send out a survey and get responses to what people will think will be most appropriate. You can do interviews, and these interviews can be very formal, like focus groups or one-on-one formal interviews, or they could be informal, just kind of talking and figuring out kind of what's going on in their lived environment to get a better understanding of how you might be better able to teach them. Or you can also just go and observe, see what they're doing in the clinic, see what they're doing in the hospital, see what they're doing on the wards, and get an understanding of, maybe what might work best when trying to figure out how to teach your learners. So again, using my project as an example, I did interviews and I talked to some of the residents and the chief residents at the institution. And I also talked to some of the primary care attendings at the institution as well. And this was some of the feedback I heard. One of the chief residents said about learning how to do the physical exam. You do it on your first week in intern year when you're rotating through the nursery. There's no other structured education. So you walk through the newborn nursery, you find a boy that was just born, you feel their testicles, and then that's the education they got. Sometimes there's a attending with them, walking them through the exam, sometimes not, but it was a lot of self-teaching or maybe observation to kind of get an idea of how to do this. Another one of the residents said, I sort of have an idea of how to do the exam, but what I have no clue about is what to write in my note if I find something. I don't know what the terminology is. I don't know how to describe it to a colleague, or when I'm referring to the pediatric urologist, I have no clue what to say. And then some of the attendings similarly said, I don't really remember any formal teaching on the exam at all. I just kind of learned how to do it on my own over the years. So this is sort of just proving that what we're seeing on the national level was also true at the local level, so that making the idea that this education, while I think was important, kind of was driven home on the local level, that it's something that could be a very valuable curriculum at the institution. Then you want to also ask what they think the best sort of curriculum would look like. What's their availability? Where are they? When are they there? And what's the best way to reach them when thinking about how to design a good educational strategy? And so we asked them these questions too. And so I talked to the attendings, I talked to the leadership of the pediatric residency program, and I talked to the residents themselves. And what I learned was that residents rotate through the primary care clinic on a 2-week block over the course of a year. While they're there, they have a daily 1-hour conference that's designed for resident education, and they're busy. They're not going to put a lot of time and effort into doing a lot of work outside of the day that they show up because they have other things going on. So you have to keep in mind that if you give them a book chapter to read that's 30 pages long, they're not going to do it. Or only a few will, or they'll only read a couple pages or just the highlights. So when thinking about what kind of curriculum you want to do, you have to sort of understand the words and the needs of the learner. And also their ability to do some sort of rotational elective is limited. They don't have a lot of time. They don't have a lot of choices. So saying, hey, why don't you come over to the urology clinic? We'll see if there's a patient with an undescended testicle that day. I can teach you how to do the exam. That wasn't really a viable approach for the learners as well, which is something I'll go into again in a little bit. So when thinking about how I want to design the curriculum for the residents, I sort of had to do it in the context of what these restraints were. So step 3 is goals and objectives. So this is a little straightforward. So what you want to do before you jump into just starting your curriculum is you want to create your goals and objectives to help to determine the basis of the context and the learning methods. It helps to focus the learner on what they should be really focusing on when going through the education. It enables a really strong communication between the educator and the learner of what the curriculum actually is and what you're trying to achieve. And it also provides the basis for evaluation in the future to see if your curriculum was successful or not. So what we wanted to do in our project was show an improvement in primary care pediatrician and resident reported comfort, confidence, and knowledge in taking care of these patients in terms of the guidelines for the diagnosis and management of undescended testicles. We wanted to see that they can display an improvement in their physical exam technique when diagnosing undescended testicles. And then we wanted to see that a few months later, that they report decreasing their use of ultrasounds that were ordered to help in the diagnosis of undescended testicles, and report lowering the age at referral to the pediatric urologist for management of undescended testicles. So these were our overall goals when thinking about how to design the curriculum. And as I'll show in a few slides, what was really nice is the goals and objectives that we set out beforehand really correlated with what the needs were from the learners on the baseline survey that we performed. So our hypothesis was that if we could perform a much more standardized education of primary care providers on undescended testicles and the proper physical exam technique, it would improve their confidence, it would improve referral patterns that we see, and optimize outcomes for our patients. And so our research question, this is putting the cart a little bit before the horse for me, talking about simulation, because I'll get into it in a few slides. But the research question was, do pediatric residents and attending pediatricians who undergo education involving video and simulation have increased comfort and confidence, improved physical exam technique and knowledge of undescended testicles, and self-report altering practice patterns as a result of the education? So again, this is all happening intertwined, right? So I was thinking about the educational strategy while performing the targeted needs assessment, while creating the goals and objectives, while going through the process of the implementation and getting buy-in from the institution. But step 4 is talking about the educational strategy and what you might think best. So this was a great study. As I was thinking about my project and how I wanted to create the curriculum, this was a great UI project that was done at VCU in 2020. That had similar goals and objectives, but had a different method of how they wanted to go about the education. So they had the pediatric residents and attendings complete a baseline survey on their confidence in the physical exam technique. The learners then went to the urology office where they were proctored on exam technique on a live clinic patient by an expert pediatric urologist, and they were graded. And then they were given feedback, and then they were graded again until they achieved a level that was deemed appropriate on how to do the exam. Then they gave a survey 3 months later and found that the learners felt significantly more confident in their physical exam skill after doing the sessions. But I had to think about it a little bit, and I thought, wow, this was great. It seemed to work, but does it work for the learners that I'm trying to teach at the institution? Does it work for our institution in general? And does it really ultimately work well for our patients? And I kind of felt there were some limitations in doing this study on a more generalizable level. And for our learners, as I had talked about, they don't really have a lot of flexibility in their schedules to be able to come to the office to do an exam on a live patient. It required a lot of organizational and scheduling support to find time for them to come to the office. And also the use of an actual patient in learning how to do the exam might be somewhat inconvenient to the patient itself, the baby, to the family members, or even the urologist during a busy clinic day. It's also possible that if you have a learner come to your office expecting to see an undescended testicle, it's not always on your schedule every day, and then it's sort of a waste of time for everybody. So I thought maybe there's a better way to do this. And then we turned to simulation and thought it might be a perfect substrate on how to teach the physical exam and the diagnosis of undescended testicles. So felt that the benefits of simulation, it's standardized, it's repeatable, it's on demand and can be performed at any time based on the scheduled learning experiences of the learners. It offers an opportunity for deliberate practice with immediate feedback and repetition that allows for mastery of the skill over time. And what I thought was super important was that it removed that inconvenience to the patients and their families of trying to learn how to do an exam on a sensitive area in their new baby. So a broad view of the educational strategy that I created was first, the learners would watch a video at home, a short video, a few minutes long, which I'll show you in a few minutes, that went over the diagnosis and management of undescended testicles and showed a brief video on how to perform the physical exam. Then we'd have the in-person simulation day, where they would perform the simulation, get some feedback on how they did, and give us feedback afterwards based on a survey. And then also follow up with them about 3 months later to see how they felt about the education and what they remembered. So this is called a flipped classroom approach. It's shown to be effective at all levels of education, from college to medical school, to residency programs. And the idea is that you're first exposed to content through online resources performed asynchronously outside the classroom, so that your time in the classroom is really spent participating and doing active learning, which is shown to be very beneficial and much more interactive for the learner. In a much more detailed timeline of the strategy, we first have the asynchronous component. They performed a baseline survey and knowledge assessment at home, and then watched a video on the guidelines and the demonstration of physical exam technique. The in-person simulation experience happened, and I'm going to go into this in a much more detail, where then after they went through the simulation experience, they took a survey on their knowledge and comfort, and then took that same survey 3 months later. So in discussing how we created the mannequin, this was step one. Me and my mentor, we drew this out of what we were hoping to achieve. We wanted to be able to create a mannequin that was able to show a normal scrotal testicle, a palpable undescended testicle, a non-palpable undescended testicle, and a torso B, or a tractile testicle, which is very difficult for some pediatricians to have an understanding of what that means. And so we took this picture to the simulation engineers at the institution, said, hey, can you help us out with making something like this? And then they created this, which was sort of a schematic of what we felt was important aspects to the physical exam that could be included in the mannequin. We wanted there to be a torso that was capable of being moved around, that was small enough and had, aside from all these diagnoses, the other things that are important on the physical exam. So we wanted to be able to show bony landmarks, including the acis and pubic tubercle. We wanted to be able to have a septum within the scrotum for each side, and have a little sort of alleyway that was a simulated inguinal canal for that testis to be mobile, both in the inguinal canal and for a retractile testicle. Then they started to create this in much more detail in the computer. They started building 3D models, which then eventually turned into our mannequins. And so these mannequins were able to simulate, again, a normal scrotal testicle, a palpable undescended testicle, a non-palpable undescended testicle, and a retractile testicle. So we move on to implementation, step 5. Again, a lot of these steps are happening intermittently as you're doing step 1 or step 2, as you're starting the process, because one of the first parts of implementation is getting support and getting the resources you need in order to perform the curriculum. As an idea, this whole curriculum from conception to performing to analyzing took a little over 2 years. And one of the first steps that I had to do was get buy-in from the pediatricians and the pediatric residency program. So as I was thinking about my goals, as I was talking to the simulation lab about creating the mannequin, I had to meet with the chief residents of the pediatric residency program. I had to get buy-in from the primary care pediatricians. I had to talk to the leadership of the pediatric residency program in order to get approval to do a research educational project on the pediatricians. So had I not done that early and just sort of went and started thinking about my education, got to that later, I might have been screwed had I not gotten all that approval. So a lot of this happens along the way as you're trying to get buy-in for your project. You want to pilot your work to make sure it's establishing the goals that you want. You want to do the curriculum, which then allows for that sort of PDSA cycle of refining it over a period of time. And I'll talk about step 6 as well, which is evaluation and feedback. So this is not just the assessment of the individual, but you also want to assess your curriculum and get feedback on how it went and how it can be improved. This allows for ongoing learning of the participants and improvement of the curriculum. For research perspective and publication perspective, it allows for the ability to answer questions about the effectiveness of the education and be able to present abstracts and publish your work. And my personal bias is that if you are thinking about developing some sort of educational curriculum or undergoing an education endeavor, it should be in the context of a research question, because this is all publishable. There's many different resources and opportunities and different types of either online publications or journal publications that want to take your curriculum and disseminate it and bring it to other institutions. So there's a lot of opportunity to get your name and your work out there. So if you're thinking about doing some sort of educational project, you should think about it in the context of a research question. So we piloted our work. One of the first things we had to do was make sure that the mannequins made sense. So at my institution, there was about 14 pediatric urologists that were sort of experts in the exam technique. So we took the mannequins And we brought it to them and said, hey, does this feel like it should feel? Can you tell us what the diagnosis is? Does this make sense to you? Anything we should change? And we changed the mannequin about 3 or 4 times based on feedback that we got from the experts. And then additionally, we tested the whole curriculum, including the surveys, performing the simulation, getting the feedback afterwards on 4 learners, 2 primary care pediatricians, 2 residents that ultimately were not going to be included in the study, just like piloting for any other project or research endeavor that you'd do. And we made minor changes to the survey and the simulation-based strategy. So diving into a little more detail about the strategy and what we did on the education. The first part was the asynchronous component. Again, we gave a survey and then showed a video. So we had 27 residents and 26 attendings complete the survey. For the residents, the majority were in their first or second year of residency. The attendings had a variation in their years of experience, with most having more than 10 years. So on a baseline survey, prior to doing the video or the simulation, less than half of both groups did not feel very comfortable in physical exam skill, identifying an undescended testicle, the diagnosis and management guidelines, describing their findings in a note or to a colleague, or knowledge of the appropriate referral patterns. And we did see some significant differences between attendings and residents in regards to this. There was no difference among residents by PGY year or attendings by their year in practice. This was great because our planned education focused specifically on these things here that seem to be the most need, right? On the physical exam comfort, and then on the guidelines for diagnosis and management. So we asked them what their prior training was, similar to the global needs assessment we had done previously. And most reported that they learned how to perform the adult GU exam in medical school, but less than 20% reported ever learning how to perform the pediatric GU exam in medical school. And in terms of residency, only 15% of residents reported getting any training in the exam, which was true for only about half of the attendings. And then we asked how they learned how to perform the exam. The highest response was patient encounter with an attending at 40%, followed by self-taught at about 26%. And so again, this kind of showed that that global needs assessment that I talked about before that showed these same problems was also true at the local level of the institution. Then we said, how often do you see these patients? Tell us, what your experience is with taking care of these patients. And so we asked what their recent undescended testicle exposure was. How many patients with undescended testicles have you seen in the last 6 months? 96% of residents thought they saw anywhere from only 0 to 5 patients that had an undescended testicle in the last 6 months. And the primary, and you could say, well, they're residents, they're rotating through, they're not on primary care very often, they're mostly in the hospital. That sort of makes a little bit of sense. But for the attendings, these are primary care pediatricians that are doing this work every day. 92% of them felt that they only saw about 0 to 5 patients with an undescended testicle over a 6-month period. So again, while it's a very common diagnosis for us, it's possible that on a per pediatrician basis, they're not seeing this as commonly as we think. They might not be as comfortable with taking care of these patients as we would expect. And this is where that sort of interspecialty communication and education becomes important. They give them board-style knowledge-based questions on different scenarios on how to take care of patients with an undescended testicle. For example, what the definition of a retractile testicle is versus a palpable testicle, how to manage a 3-month-old with a palpable testicle, et cetera. There was no significant difference in correct response by PGY year or attending year in practice for any category. Focusing on this one where they seem to do the worst, this was a question on the management of a 6-month-old with a non-palpable testicle. And we wanted to sort of understand if they weren't choosing the correct response, what were they doing? And it turns out in most cases, they were ordering an ultrasound to look for a testicle in these 6 months old. 70% of residents and 65% of attendings opted to get an ultrasound in these patients, which, as we know, is not sort of the correct management. Additionally, the management of a 1-year-old with a retractile testicle, which, as we know, is normal and can be watched. 66, about 2/3 of residents felt that they should refer to a pediatric urologist for management, and that was true for about 40% of attendings as well. So after completing the survey, learners watched a video on the guidelines and physical exams. This was the video I created. It was about 7 minutes long. It went through the AUA guidelines on the diagnosis and initial management of undescended testicles. In addition to showing the guidelines, we showed an example of physical exam technique using 6 steps that we had created that we knew were in the literature on how to do the proper physical exam for an undescended testicle. So again, this whole asynchronous component, including filling out the survey and watching the video, took about 8 minutes. And then what they did was they came in. That was sent out anywhere from a week to 2 weeks before the planned simulation day. And they were given any amount of time to fill out the survey and watch the video beforehand. And then we went to the in-person simulation day. So we had 43 residents and attendings complete the sessions. They were one-on-one with a pediatric urologist, consisting of initial exam attempts by the learner, followed by directed feedback from the educator, and then a repeat exam. Participants were graded on the exam technique, and this was used to evaluate for mastery of the physical exam. So this is based on a couple of educational framework, including mastery-based learning and rapid cycle deliberate practice with directed feedback. There's a well-defined task. You get detailed and immediate feedback and an opportunity for repetition until you reach a mastery level. And what we found was that overall, for the majority of learners, it only took 2 attempts for them to reach mastery level on how they performed the exam. And this pointed to the value of in-person practice with mentoring, even having already watched a video on how to do the exam. So they already seen the video, and yet they weren't really at a mastery level yet. But adding in the simulation component and doing an in-person teaching on how to do the exam, they really got a better understanding of how to do that physical exam after only a couple attempts. On average, the teaching took about 5 minutes with each learner. And that was all it took for them to reach mastery level. So something that we were able to fit within their availability of an hour-long lunch session in the middle of a busy clinic day when they were available, and we had to give them sort of a here's what you need to know education in the moment, which they felt was valuable. So then immediately after they filled out a survey, I had QR codes sitting at the end of the table so that as they were walking out of the room, they scanned it and filled out the survey on their way back to lunch so that we knew we would get responses. And what we found was that immediately after completing the simulation sessions, over 90% of both residents and attendings responded to feeling more confident in sort of every category we asked, including the ability to perform the infant exam, the ability to diagnose an undescended testicle, the ability to explain and document their clinical findings in a note, and their ability on the management and the appropriate referral patterns for these patients. We asked them what the most useful component of the education they felt was. Was it the guideline lecture? Was it the physical exam video? Or was it the mannequin simulation sessions? About 90% of the residents felt the in-person simulation with the mannequin was the most useful component. This was true for about 70% of the attendings as well, though a quarter of them did find the guideline lecture to be the most useful for them. And I had many reach out to me afterwards over the course of next year, just asking me to send them the lecture so that they could review it prior to seeing patients in the office, et cetera. So then we asked them, what did you think of the education in general? What did you think of the curriculum? And 95% of residents and 100% of attendings either agreed or strongly agreed on recommending the curriculum to other members of the pediatric residency and felt that the clinical teaching session should be standard in their pediatric residency program or their CME attending education series. We also got some qualitative open-ended response feedback as well for the residents. You can see here based on these responses that they felt much more confident in their physical exam. They felt much more comfort in taking care of these patients, and pointing to the value of how we created the curriculum, they felt that the video was the perfect length and the didactic session was helpful. This was similar for the attendings as well. Again, they showed much more, they responded using words that I was hoping to see. They felt much more confident in their ability to take care of these patients and do the physical exam. And then again, thinking about how we created the curriculum for their needs, they felt it was short enough to fit in their busy education day, in their busy clinical day, and was a valuable educational curriculum and experience for them, which I was very happy to see. So we again gave the same knowledge-based questions that we gave on the baseline survey, on the immediate post-op survey, and saw improvement in responses on almost every question. And again, focusing on the one that they did the worst at, which was the management of the 6-month-old with a non-palpable testicle, you can see they all did much better after the education than they did before. Now the ultrasound order rate went to 0 from 2/3 on the baseline survey. So this isn't novel, right? You teach someone something, they're going to learn, and you're going to see better responses afterwards. But the question is, does it stick? So we followed up 3 months later and sent them another survey to see how they're doing, what they remembered about the education, and what they felt about the curriculum. So again, going back to that sort of how comfortable they felt with all these different components, the percent feeling very comfortable compared to prior. you could see statistically significant improvements in the physical exam, in the diagnosis and management guidelines, and in how they describe their findings to a colleague or in a referral. And again, these were our main goals and objectives of the education. So it was really nice to see that we sort of hit our mark based on what we were trying to achieve when we set out at the beginning. So we asked them how they've changed their practice. About 58% of respondents had seen a patient with undescended testicle in their clinic since doing the teaching session. And of those, 92% used their experience to modify their physical exam skill for the patient that they see for a testicular exam. A little under half said that they changed the way they document their physical exam findings in a note or in a consult request to a pediatric urologist, which is obviously beneficial for us. A third said that if they have concerns for undescended testicle, they'll refer that patient to a pediatric urologist at an earlier age than prior to an educational session. Again, one of our goals is getting the patients that really have an undescended testicle, seeing us in that window of 6 to 18 months and not waiting on it. And then 40% said that they decreased the number of ultrasounds that they ordered for concern for an undescended testicle from prior to the education. So of course, I would love to have seen this number be 100%, or at least the majority, but 40% was at least a much better improvement than we had seen from before. And again, one more time, we give them the same knowledge-based questions that we did on the baseline survey and on the immediate post survey. And you can see, again, they did very well overall. And focusing again on that 6-month-old with a non-palpable testicle, only one person responded that they get an ultrasound on that patient. So showing that this really stuck a few months later, and we kind of got our point across. So that was very nice to see. So conclusions overall, pediatricians don't really feel very comfortable with the care of undescended testicle patients at baseline. A combined video and simulation-based education is effective at increasing comfort and knowledge in the diagnosis and management of undescended testicles in both the immediate and the long term. Simulation with the novel mannequin played an important role in the education. And the educational strategy is generalizable to other institutions and other primary care providers. And so that's when we think about after you complete these 6 steps, you realize it's a cycle, right? Not undifferent from QI and doing a PDSA cycle. You're always looking for improvement, right? So we didn't want this to be a one-off thing. We didn't want this to say like, this is the best way we do things and we're just going to keep doing it this way. You always want to improve and you know, give better education over time and have it be an iterative process and get that feedback so that you can. So where are we now? It's now, the curriculum is a standard part of the primary care pediatric rotation at Boston Children's where we did this work. So I'm very pleased that even though I'm not there anymore, it's still continuing and there's enough buy-in from the pediatricians and also my colleagues in pediatric urology that my bosses and mentors are still going over there and taking the time to do the education while I'm no longer there. So on a personal level, I find that very valuable and I'm glad that it's continuing. We've made improvements and updates in the mannequin. And as well, I'm working with a team at Boston Children's to create a much more professional video than the little PowerPoint that I made previously so that it can be disseminated and published on a more national scale for people to be able to use. It's being used at CME courses outside of Boston Children's. And then also we want to see, you know, Boston Children's is obviously a tertiary care center with a certain type of resident, a certain type of primary care pediatrician. We want to see does this education work outside the walls of Boston Children's. So we're working on a multi-center external validation site where we're working with about 4 or 5 different centers around the country who are also going to perform this education at their institutions. So the rub for that is that the only guidelines we have is that you use the mannequin because we feel that's a very important part of the educational strategy. But if your learners and your institutions have a different educational time frame that they're able to complete this, or different strategies or needs, they can make sort of any educational curriculum or strategy they want in order to use the guidelines and teach the physical exam with the goal of then putting all of the surveys together, grouping them to show that the education does work on a more national scale at a multi-institutional level. We have applied to lead an education course at the AAP next year, and we're hoping to be accepted so that we can do this on a national level for primary care pediatricians and other providers that take care of these patients. And also ultimately, this is all provider level outcomes, but we want to see what happens with our patients. So I'm trying to figure out a way to figure out how we can get better understanding of how this education affects our patients, whether it's changes in ultrasound ordering rate, or a change in the average age to referral of a pediatric urologist or age of time of work at PECSI from both before the education to afterwards. So that's general overall what that study was about. I also wanted to talk about sort of a project that's more at the onset at the beginning of this cycle that I'm starting to perform here with some of the work that I'm interested in as part of the Education Scholars Fellowship that I'm a part of here at Yale. Excuse me. The title being, Does Medical School Exposure and Rotation Experience Affect Future Attrition in Surgical Training? And this is a qualitative research study where I'm going to be interviewing learners about their experience, and I'll go more into detail about that in a few minutes. But the overall needs assessment generally for this is that attrition rates in surgical residencies are higher than those in non-surgical residencies. In general surgery, it's anywhere from 3 to 6% annually. And in urology, it's anywhere from 1 to 4% annually that someone's dropping out of the urology residency program. And as you can imagine, the effects of attrition are significant for both the trainee and the residency program. For the trainee, there's financial implications, there's academic implications, and there's obviously life costs to leaving a program and making that decision to change careers. For the residency program, you can imagine it creates a myriad of issues, including issues with scheduling, issues with recruitment. And obviously, it doesn't look good if someone has left your program. And then it also can further demoralize the remaining residents that are in your program from losing a colleague and trying to keep them satisfied despite increased workload from being understaffed. So a lot of work has gone in previous studies, both quantitative and qualitative, have sort of looked for reasons for attrition. And as you can imagine, this is multifactorial. There's a lot of individual local levels at an individual residency that may be important. But most of the studies, if not all of them, have really focused on factors during residency that have led to someone leaving the program. But no one's looked sort of earlier to understand sort of what happened at the medical school level when that learner, that student is sort of making the decision to go into residency and seeing how that correlated with what their experience was when they actually were involved in a residency program. And so that's my sort of hypothesis and thought process, is that surgical rotations in medical school often involve observation rather than performance. And it's the only field I can think of in the world where you choose to devote your life to something without ever having done it before, right? You're in medical school, you're watching someone, and you say, oh, I think I can do that. I'm going to apply. And then you spend 5 years to 8 years of your life doing that thing before you're ready to do it. And maybe you find out too late while you're already in the program that maybe it's not for you. So if we can find something earlier to get a better understanding for the medical students of sort of what goes into being a surgeon, being a part of a surgical residency, that may help understand and give sort of a better understanding to medical students sort of what goes into that and if it's for them. And so we've seen this in some surveys that were sent out to residents and people that have left residency programs, that there's discordant expectations set during medical school of what a surgical residency and careers entails. There's a disconnect between the expectations of a surgical residency and life as attending and what actually is in reality. And then we found that if you had a much better quality clerkship experience in medical school, you're more likely to stay in a residency until completion. So my specific goals or objectives are sort of to understand what factors during a medical school rotation experience lead participants to apply into a surgical or surgical subspecialty training program and career. I want to see sort of what differences in any in expectations that were set during medical school of a surgical career and what they actually experienced during a residency. And then if there are differences between the two, see if those differences are what potentially contributed to their decision to leave a program. So the way I'm going to do this is through a targeted needs assessment, where I'm going to interview participants that either have dropped out of a urology residency program or recently finished one, and perform an inductive analysis on their medical school experience and their experience on if they decided to leave the program, why. And what I really want to focus on is that technical skill education. So what kind of experience did they get performing surgery at medical school, at the medical school level, to get a real understanding of if they felt they had the skill, if they felt they had the sort of intuition and the ability to be a surgeon and what that means. But also understand what other factors they heard during medical school as well that may have led them to go into a residency program. And I feel that performing interviews and taking an hour long to really ask them pointed questions about their experience using this qualitative approach will allow for a much more in-depth insight about these individuals' attitudes and expectations and give us a much better understanding of what we might understand about what happens with these learners. And so why is this important? So at an undergraduate medical education level, if we do find that there are discordant expectations set during medical school rotations, this could lead to an opportunity for improvement on how we teach and expose medical students to a career in surgery. It's possible that improved simulation experiences at the medical school level could help students get a better understanding of the rewards and stressors of a career in surgery. It could lead to changes in the selection of those that apply for a residency program into a surgical field that potentially lower future attrition rates. So again, this is all sort of happening intermingly. And as you're working on this part of the study, I'm also talking with the Yale Center for Healthcare Simulation about this topic and improve surgical education in medical school. So while this study is ongoing, I'm working with them to sort of develop a immersive, novel simulation experience for surgical education so that students at the medical school get a much better understanding of what being an operating surgeon truly means and gain hands-on experience this exposure to see if that's something that is right for them prior to applying for that program.